The main issue revolves around bone preservation. By doing the resurfacing, you're able to preserve the patient's femoral neck and most of the femoral head, and that's the main difference. And that happens to be also its weakness. So women in their 60s, it doesn't make a lot of sense to go ahead and keep their femoral neck because that's likely to be a weak point as they get into their 80s. So women over the age of 60 really need to think long and hard about doing something like this. Just like it is not a surgery that every patient should have who has hip arthritis, it's not a surgery that every hip surgeon should do, and not every orthopedic surgeon should be doing this kind of operation. It certainly makes no sense just to do a few of them a year because you could tell from the exposure there that it takes a lot more work than a standard total hip, and it's more exacting, and there's a lot more room for error. So it makes sense that fewer surgeons are doing them. Surgeons are being trained on it every week in various locations throughout the country and abroad, but it's being offered to surgeons who are known to have good outcomes in hip especially. We have one of the more extensive experiences in terms of resurfacing here at New York-Presbyterian. For the last almost 7 years, I've been doing various forms of resurfacing of the femoral neck and head, and that's really the critical portion of the operation. The rest of the exposure can be done by most surgeons who do expansile approaches for the hip, for example, for a hip replacement revision. Any surgeon who does a revision hip could probably get the exposure that you saw today, but there's some speciality that is required to go ahead and get the femoral head and neck shaped in just the right way to make sure you don't notch and that you avoid femur fractures and especially the early failures that can happen.